you, Dan. Appreciate the opportunity to be here. So I think a lot of what I'm going to say is also going to dovetail on some of your questions and what the real world experience is with this therapy. So my version of the real world is Baptist Health South Florida, which is a big employer. It's comprised of 12 hospitals from Boca Raton down to the Florida Keys. Baptist Hospital is the flagship hospital in Miami, and it's sort of a tertiary referral center and an early adopter of this therapy. I think one of the biggest and most important ways of getting your staff, your colleagues to buy in is to have a local champion. So it would be someone like you. In our case, it was Dr. Quesada. And you have to present the data. People have to believe in it. And over time, the staff especially really become the biggest advocates. They're the ones asking, well, is this a patient that we should do this on? Because they start to see the outcomes. So when you share your own data, then the buy-in starts to get there. So my summary statement from the outset is that this is doable in the real world. Sort of community-based hospitals can do this, and you're going to see improvements in your patients' outcomes. Much of this has been talked about already from the previous speakers, but the value proposition of supersaturated oxygen is that it fills that unmet need of unchanged outcomes of death and heart failure in anterior STEMI patients post-PCI. And so the graphic on the left shows that we've done a good job. There are better outcomes now because of door-to-balloon time and all that, but there's been a steady, unchanging level of late outcomes that suggests that opening the artery alone is not enough. As Dr. Sutton and others have shown, microvascular dysfunction impacts infarct size, impacts adverse LV remodeling, and ultimately impacts LV function. And why I think it's important that LV function is at the end of that string is because it's something that we can measure. Everyone who does medicine knows what the EF stands for. Patients know what the EF stands for. So it's something that you can say to your colleagues, to your staff, to your nurses, to your techs, look at the improvements in EF that we're going to get. And I think that's really how you get buy-in for this therapy. So I'm going to start with two cases that highlight our process, and then I'll briefly show you what our data is, and then I'll wrap it up. This was our first SSO2 patient. It was June of 2021. This was done by my partner, Dr. Ramon Quesada, who's a big believer and was our champion. So a 53-year-old man who presented with an anterior STEMI. Interestingly, even for the very first case, so as you may know, the audience should know, it's FDA approved for LAD STEMIs presenting within 6 hours. This gentleman had stuttering symptoms of 12 hours duration, but that didn't stop him. But I'll show you briefly the film. So he had an occluded LAD with some collateral filling from the right to the LAD, and that becomes important because what it said to him in the heat of the moment, that plus the clinical scenario, the symptoms were sort of stuttering. There weren't 12 hours of crushing chest pain, that he expected there was viability in that anterior wall, and that's what led him to offer the therapy to this patient once he'd opened the occluded artery. You can see from the catheter location that he did this from a radial approach. These images here are right after the SSO2 therapy. So again, blush is not everything, but what a beautiful blush. And you can see the anteroapical and apical hypokinesis, EF probably 30 to 35%. I don't have all the echoes for these two patients, but the very next day we see an improvement in the LV function. Still not normal. There's some apical septal hypokinesis, but better than it was the day prior. So that was our first patient, still doing well, and has had complete recovery of LV function months later. This gentleman was 42 years old, presented more classically within 2 hours, had VTVF in EMS, or as we say in South Florida, fire rescue. He was brought to the lab by another one of my partners. No visible collaterals here, an occluded proximal LAD there. The wire's already down. Here we see after stenting, another lovely blush. And again, the interventionalists in the room will know that you don't always see that blush. Now, these are two cases, two anecdotes, but you know what? Many anecdotes make a real story. Also very significant LV dysfunction. Next day, completely normalized LV function. I mean, look at that apex. It's just a wonderful thing, a 42-year-old man. So you have some cases like this, and then you show your own data, and the staff believes. So each one of us wants this for our patient, and the notion that doing an extra hour to get this is somehow an inconvenience, it really is laughable. So I think these are the ways that you teach your colleagues and your staff that this is why we do what we do. So our data is shown here, and it was presented in abstract form at this meeting. And I'll just walk you through it. This is really the meat of the talk. So in the green is the standard PCI only treatment, and we did sort of a contemporaneous look at 22 patients around the same time as our SSO2 program was beginning, who got just usual standard of care. In the blue bar, we see the SSO2 patients who were treated within the FDA-approved and indicated guideline of under 6 hours. That was 22 patients. And then in the dark blue are SSO2 patients who were treated after 6 hours, and I think that was only 6 patients. And what you see is that the first month in the PCI-only treatment, so the standard of care, get to the lab, you open the artery, you put your stent in. We saw a percentage increase in the EF of 3%, whereas in the SSO2 treated patients, the EF increase, the percent increase from baseline pre-discharge to 1 month was 16.8%, and for the greater than 6 hour presenters, 15%. So sort of dramatic, noticeable, eye-catching results that held up to 3 months out. So in the PCI-only group, 5% increase from baseline in EF at 3 months, 23% in the SSO2 treatment group under 6 hours, and in the greater than 6 hour group, again, a small number, 22%. Importantly, we didn't see any hint of negative outcomes, 0% stroke, 0% need for ICD implants, 0% rehospitalization in the SSO2 group, and no mortalities and no reinfarctions. I'd point out here also, just to give you a flavor of the real worldness of this. So at Baptist Hospital in Miami, there are a total of 8 interventional cardiologists. 6 of us now are employed, 2 are non-employed, and the second case that I showed you was of one of our non-employed partners. So I think really what you need is a local champion, and once you have a good leadership and a strong champion, even folks who may have less incentive to spend more time at the hospital will really buy into this therapy and avail your patients of this opportunity. We're going to look in our hospital at trying to get a little bit more data around the later than 6 hour presenters, and the thought is that patients who have established collateral flow at the time of their presentation, whether it's at 8 hours, 10 hours, or in the first case I showed you 12 hours, that presence of collateral flow may be an indication that that muscle is viable and likely to improve. And so in those patients, after, of course, standard of care, opening the artery, we'll try to randomize them into just standard of care, or then to do SSO2 if they presented later than the current FDA-approved indication. Gratifyingly, our data is very consistent with other real-world sites that have supplied data to Zoll. So here we see in other institutions, so ours is Hospital B, but similarly impressive increases in ejection fraction from baseline at 1 month, so 15% through 20%, and in the sites marked with that orange positive sign, no reported readmissions. And this data and this trend holds up till 3 months out. So very encouraging data that certainly is consistent with the initial trials, and we hope to see continue to be shown in the real SSO2 registry. So in closing, intracoronary SSO2 infusion at the time of primary PCI for LAD STEMI results in statistically significant improvements in LVEF compared to standard PCI alone. I think that is the headline here, and if you take nothing else from this conference, that should be it. What else do we want for our patients but improved EF? And further, in our particular setting, in patients, that benefit holds in patients presenting both within the currently approved 6 hour window as well as patients presenting late and who have collateral circulation.
Dr. St. John, you would not let a normal EF limit you in using this, would you? I mean, we're talking about
EF
abnormal. I would still use this on somebody who would not have a wall motion out of the mouth.
I would also, and they may have less to benefit, but I think any benefit when you have the opportunity is probably worth it.
Are there any other additional questions? I mean, it kind of gets back, your comment here from before kind of relates a little bit, like, should every patient with an anterior STEMI get this therapy? So obviously the way medicine advances is we're supposed to do a clinical trial, a randomized trial, we get a result, and then the results, we interpret the limitations of the study, and then we apply the therapy if it was shown to be beneficial. So kind of technically, anyone who meets the criteria for the AMI-HOT and the IC-HOT study would qualify for this kind of therapy. So, there was no, as I remember, there's no EF criteria for either of those trials.
In most cases, in our STEMI practice, we do the EF at the end anyway. So I don't usually know what the EF is before I've given the treatment, to be honest.
Question from the back?
Yeah. So one of the things you brought up is that it takes extra time, and you get people to buy into it, extra time. So in your experience, what sort of practices have you set up in your lab that make this as quick as possible, that make things more streamlined?
Yeah, you can't make 60 minutes less than 60 minutes, but I think communication is the most important thing. And by that I mean the moment that you have in your mind as the interventionalist, this is going to be an SSO2 patient, share that with the team. So when I'm seeing someone in the ED or even if just on the phone from the ED doctor, I'll send a text to the group. This is an SSO2 candidate. So they already have in their minds, all right, we're going to do the PCI, then we're going to do the additional time. What some of the staff have said to me, they have a lot of other things to do. So the nurses have a lot of catching up to do with their documentation and those types of things. Certainly as a physician, we have a ton to do in terms of dictating, speaking to families, putting in orders. So I'd say at least 30 minutes of that time is used just doing other stuff that you would otherwise have to do. It's not no extra time, but it's a lot of stuff that gets done in that time.
So this is going to be in part the topic for the next talk.
Yes, you're right.
So we can really maybe dive right into that. Was there's another question? So the next talk is going to be from Dr. Sandy Nathan, who's going to talk about how to initiate SSO2 program. I think some of these types of practical questions will be addressed.
How do I get out of here and get you into there? Just